Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
This is another chemotherapy and anti-neoplastics episode. Today, we're going to be discussing the use of biologic and other targeted anti-neoplastics in gynecologic cancers. Sydney, what are our learning objectives?
Our learning objectives are to understand that biologic therapies target specific proteins or actions in the cell to enact their cancer-directed effect, to acknowledge that administration techniques and dosing differs for each of these therapies, to recognize that their unique side effect profiles often result from their unique targeted actions, and to realize that many of these therapeutics have options for dose reduction versus discontinuation, with management of adverse events dependent on the grade of the adverse event.
Today's episode is broad, and we'll be covering a lot of different agents and targeted pathways. This is by no means an exhaustive list of targeted agents used in gyn-onc, as this is one of the fastest areas of research in our field, and new agents are being evaluated and approved frequently. We're going to cover agents that are currently more commonly used and either FDA approved or recommended by the NCCN at this time. Send us a message if there are agents you want to learn more about, and we can add them to a list of future episodes. We're going to put some figures which depict the targeted pathways that we're discussing today on our website. When learning about these agents, I find that seeing the pathways really helps me understand why certain agents work in certain scenarios and why we combine some agents. We're going to start by talking about anti-angiogenic therapies. The one that we're probably all most familiar with is bevacizumab, which we covered in episode 15. Tyrosine kinase inhibitors are other agents which are used to target VEGF receptors. Tyrosine kinases are part of cell surface receptors which bind to growth factors. When growth factor binding is facilitated, this leads to overexpression of cells and proliferation. Because they're on the cell surface, tyrosine kinases are appealing therapeutic agents. Most tyrosine kinase inhibitors that target VEGF receptor, like pazopanib and cediranib, are multi-kinase inhibitors that also target other receptors, like platelet-derived growth factor receptor, c-KIT, among others. Pazopanib, a multi-kinase inhibitor, is primarily used in recurrent ovarian cancer and in advanced or recurrent uterine sarcomas, and it has shown activity in both of these settings. Pazopanib is administered orally in a once-daily regimen taken without food. Common adverse events include fatigue, hypertension, diarrhea, elevated liver enzymes, nausea, vomiting, and abdominal pain. The hepatotoxicity can be severe, and so liver enzymes should be obtained at baseline, 2 weeks after starting treatment, and then repeated during treatment. Less common but also severe side effects include cardiotoxicity with QT prolongation and risk of CHF, so EKG, electrolytes, and echo should be done before and during treatment. As with other anti-angiogenic agents, hemorrhagic and thrombotic events are possible. Fatal hemorrhage and PE have occurred with pazopanib treatment. Impaired wound healing can also occur, as can GI perforation and fistulas. This drug needs to be held around the time of surgery to reduce the risk of these events. Some other unique potential side effects include interstitial lung disease, posterior reversible encephalopathy syndrome, hypothyroidism, proteinuria, infection, and tumor lysis syndrome. Pazopanib does not have a specific FDA approval for gynecologic cancers, but it is included in the NCCN guidelines, and it has FDA approval for renal cell carcinoma and soft tissue sarcomas.
Lenvatinib is another tyrosine kinase inhibitor, which non-selectively inhibits angiogenesis through VEGFR 1 through 3, as well as FGFR, PDGFR, KIT, and RET inhibition. Lenvatinib is FDA approved in conjunction with pembrolizumab for the use of in advanced endometrial cancer, which is MMR proficient, after progression on prior systemic therapy based on the results of Keynote 775. Through targeting multiple receptor groups, lenvatinib inhibits angiogenesis, tumor growth, and cancer progression. Lenvatinib is dosed orally daily, and typical dosage is 20 milligrams. Capsules need to be swallowed whole, but they can also be administered through a feeding tube mixed with water if necessary. Dose reductions going as low as 8 milligrams per dose are possible to help manage adverse effects, and there have been studies evaluating starting at lower doses to reduce toxicities, with seemingly preserved efficacy. When talking about side effects for this drug, we're going to talk about side effects from the combination of lenvatinib and pembrolizumab together, as currently this is the regimen that patients received in Keynote 775. And there's no indication for lenvatinib monotherapy in gynecologic cancer. This regimen is quite toxic. 97% of the patients in the study experience adverse events, with 89% experiencing at least a grade 3 event. In Keynote 775, there was a 5.7% rate of fatal adverse events in the treatment arm attributed to many different organ systems, including pneumonia, AKI, MI, various GI complications, including perforation and hemorrhage, myelodysplastic syndrome, and PE. Greater than 65% required a dose reduction or interruption, and 33% of patients discontinued the drug combination. Most common side effects included hypothyroidism, hypertension, fatigue, diarrhea, and musculoskeletal disorders, which all occur in greater than 50% of patients who take this combination. Nausea, vomiting, decreased appetite, as well as stomatitis also occur in greater than a third of patients. Because the regimen is so toxic and so frequently leads to dose interruption, some providers suggest considering starting at a lower dose, especially in frail patients. Maya, are there other targeted agents which have anti-angiogenic properties?
There are. We're going to switch gears and talk about a monoclonal antibody with which we will all be familiar, trastuzumab. Trastuzumab targets and blocks the HER2 receptor, which flags the tumor cell for destruction. HER2, also known as ERBB2, is part of the EGFR tyrosine kinase family. So although trastuzumab is not a TKI like we've been discussing, it's acting at a similar point in the cell. Trastuzumab has cytotoxic effects. It arrests the cell during the G1 phase of the cell cycle, and it also suppresses angiogenesis. Let's first talk about trastuzumab alone, and later we'll discuss its use as an antibody-drug conjugate. Trastuzumab is used in HER2-positive uterine serous cancer and HER2-positive endometrial carcinosarcoma, in combination with carbotaxol, as studied by Fader et al., in which HER2 positivity was defined as having both 2+ or higher expression on IHC and FISH gene amplification. Head back to our Uterine Part 3 episode where we went over this study in more detail. Overall, this regimen was well tolerated. There were no discontinuations in this study for toxicity, and the toxicity was similar between the chemo alone and trastuzumab plus chemo arms. However, trastuzumab does have some unique toxicities. It can be cardiotoxic, so a pre-treatment echocardiogram is necessary, and it should be repeated every 3 months during treatment and at treatment completion. The cardiotoxicity is generally reversible, but the risk is higher in patients that previously received anthracycline chemotherapy or had previous chest wall radiation. Treatment should be held if there's a reduction in left ventricular ejection fraction more than 16% from baseline, or if the LVEF is below normal limits and has dropped more than or equal to 10% from baseline. If treatment is held for at least 4 weeks and the left ventricular ejection fraction returns to normal, trastuzumab can be restarted. Additionally, trastuzumab can cause infusion reactions, which can be serious and sometimes fatal. These typically occur within 24 hours of administration, and most are mild. If a patient experiences anaphylaxis, angioedema, interstitial pneumonitis, or ARDS, treatment should be discontinued, and if the reaction is severe, that warrants permanent discontinuation. Sydney, I mentioned that trastuzumab is also part of an antibody drug conjugate. Can you walk us through ADCs in general and tell us about that?
Absolutely. Antibody drug conjugates, ADCs, include a targeted monoclonal antibody, like HER2, which is fused by a linker to a small cytotoxic molecule, which is known as the payload. The linkers can be cleavable or non cleavable, which affects where the payload gets released. With cleavable linkers, the payload is released in lysosomes, and cytotoxic agents may evade the cell and kill nearby tumor cells via bystander killing. With non-cleavable linkers, the linker gets degraded intracellularly, so the cytotoxic agent remains intracellular and thus has less off-target effects. Trastuzumab deruxtecan, the brand name Enhertu, is a HER2-directed ADC. Deruxtecan, the cytotoxic agent, is a topoisomerase inhibitor. Trastuzumab deruxtecan was and is being evaluated in the Destiny series of clinical trials, which are tumor-agnostic trials. It has since been approved by the FDA for unresectable or metastatic HER2-positive solid tumors, which are IHC3 positive. In the Destiny studies, gastric cancer staining cutoffs were used, with IHC2 plus or 3 plus not requiring FISH gene amplification. Ongoing studies are evaluating use in patients with less HER2 staining. This medication is dosed intravenously with a starting dose of 5.4 milligrams per kilogram every 3 weeks. Dose reductions are available. Trastuzumab deruxtecan is highly emetogenic and prophylactic antiemetics should be given. 69% of patients will experience at least grade 3 nausea. Other common serious adverse events include vomiting, diarrhea, constipation, stomatitis, abdominal pain, and dyspepsia. Note that these are all GI tract related adverse events. Patients can also experience cardiotoxicity with left ventricular dysfunction, fatigue, edema, musculoskeletal pain, and decreased appetite, as well as dermatologic effects of alopecia and rash, respiratory symptoms like URI, cough, pneumonitis or interstitial lung disease, dyspnea, and headaches. If patients experience pneumonitis, the median time to onset is 5.5 months of treatment, but the range of onset is wide. There are some specific recommendations for managing pneumonitis and when using this drug. Consider a baseline oxygen saturation, pulmonary function tests, and high-resolution CT. Consider repeating the high-resolution CT every 12 weeks and more frequently if respiratory symptoms are present. Treatment should be interrupted even with grade 1 pneumonitis, and if patients have grade 2 signs or symptoms, treatment should be permanently discontinued and treatment with steroids initiated. For left ventricular dysfunction, treatment should be interrupted if the left ventricular ejection fraction gets below 45% and has decreased 10 to 20% from baseline. If the left ventricular function recovers to within 10% of baseline, treatment can be resumed. But if the left ventricular ejection fraction gets below 40% or the change from baseline is greater than 20%, treatment should be discontinued permanently. There are also specific recommendations for management of cytopenias, which can be found on the drug website. This drug has not been studied in patients with existing cardiac dysfunction. Maya, how else have antibody drug conjugates been employed in gynecologic cancers?
Mirvetuximab soravtansine, aka MIRV, and the brand name Elahere, is an ADC which targets a transmembrane glycoprotein, folate receptor alpha, which is encoded by the FOLR1 gene. Folate receptor alpha overexpression is associated with platinum resistance. Soravtansine, the payload, is a microtubule disrupting agent. Currently, MIRV is used in ovarian cancer and has been evaluated in the Mirasol, Forward 1 and 2, Soraya trials, and the ongoing Gloriosa trial. Based on the results of these trials, the FDA approval is restricted to patients with expression of folate receptor alpha in greater than or equal to 75% of cells and with moderate to strong staining. The NCCN guidelines also include MIRV with BEV for folate receptor alpha expressing tumors that have greater than or equal to 25% expression, As in the Forward 2 trial, benefit was seen across folate receptor alpha expression levels, with stronger response at higher expression levels. MIRV is dosed intravenously with a starting dose of 6 milligrams per kilogram using an adjusted ideal body weight and with dose reductions available. Patients should be pre-medicated with an IV corticosteroid, an antihistamine, an antipyretic, and an antiemetic. MIRV has some unique toxicities, which you may have heard of. Ocular toxicities are the most common, occurring in 60% of patients. This can show up as blurred vision, keratopathy, and dry eye. 11% of patients will experience at least a grade 3 event. These occur pretty quickly after starting the drug, with median time to onset of 5 weeks. Only about half of patients will have complete resolution of these symptoms. Prevention of ocular toxicity includes use of a lubricating and ophthalmic topical steroid eye drops, as well as an eye exam prior to treatment initiation and during treatment. Patients also need to be instructed that they can't wear contact lenses during treatment. There are specific management recommendations for keratitis and uveitis that depend on the grade of injury. Remember to consult the drug prescribing information if your patient experiences any of these events. The prescribing website even has helpful sheets that patients can take to their eye visits to have the toxicity grade and the recommendations for management written down. Other side effects include pneumonitis, which is usually a grade 1 to 2, and a risk of peripheral neuropathy, which occurs in more than a third of patients. Due to a risk of hepatic toxicity, this drug should be avoided in patients with moderate to severe hepatic impairment. If patients are on other drugs that are CYP3A4 inhibitors, consider drug interactions. Sydney, I think there's one more ADC to cover. Can you tell us about tisotumab vedotin?
I can. Tisotumab vedotin, also known as Tivdak, is a human IgG antibody against tissue factor that's combined with a payload of monomethyl auristatin E, MMAE. Tissue factor, aka platelet tissue factor, is abnormally expressed on the surface of many tumor cells and is associated with tumor-related angiogenesis, thrombogenicity, tumor growth, and metastasis. MMAE is a microtubule disruptor. This drug is used in cervical cancer and has been evaluated in the ANOVA-TV clinical trial series. Tisotumab vedotin is dosed intravenously with a starting dose of 2 milligrams per kilogram every 3 weeks. Dose reductions are available. The most common adverse effect that patients experience with tisotumab vedotin includes bleeding and hemorrhagic events, including epistaxis and vaginal bleeding, GI toxicities, including nausea, constipation, decreased appetite, and diarrhea, ocular toxicities such as conjunctivitis, corneal toxicity and dry eye, peripheral neuropathy, alopecia, fatigue, and anemia. In ANOVA-TV 301, treatment-related adverse effects led to treatment discontinuation in 15% of patients in the experimental group, compared to 4% in the chemo group, and most of these were related to ocular and peripheral neuropathy toxicities. Management of toxicities depends on the grade. For ocular toxicities, these will likely require diagnosis by an eye specialist who will do exams to check for keratitis, visual acuity and ulceration, and conjunctival defects. Typically for first occurrences, treatment can be held until resolution and often can be restarted, but make sure to refer to the prescribing information for specific details. Other adverse events that warrant treatment discontinuation permanently include grade 3 or higher peripheral neuropathy, any pulmonary or CNS hemorrhagic events, grade 3 or higher hemorrhage events in other locations, grade 3 or higher pneumonitis, or grade 3 or higher severe cutaneous reactions such as Stevens-Johnson syndrome. Like with mirvetuximab, prevention of ocular toxicity includes an ophthalmic exam prior to initiation and during treatment, avoidance of contact lenses, and eye drops. For tisotumab vedotin, steroid drops are required, as well as vasoconstriction drops, lubricating eye drops, and cold packs to keep the eyes cool during treatment. I think that covers ADCs for today. Maya, can you tell us about trametinib, another targeted agent?
Trametinib is an inhibitor of mitogen-activated protein kinase enzymes, MEK 1 and 2. This drug inhibits the MAP kinase pathway downstream from the HER2 receptor. It's used in low-grade serous ovarian cancer and was evaluated in GOG 281. This drug is dosed orally, and it must be taken in whole tablets on an empty stomach, and it has to be stored in the fridge. 2 milligrams daily is the starting dose, with reductions available. In GOG 281, this was necessary in 11% of all cycles, and 70% of patients required at least one dose reduction. More than a third of patients discontinued the drug due to toxicity. Most common adverse events include fatigue, skin rash, anemia, and GI adverse events. Some providers use prophylactic clindamycin cream or acne medication to prevent rashes. Additionally, more than a third of patients experience hypertension of any grade. Some unique adverse events include retinal toxicity, including retinal detachment, which can occur in 2% of patients, and decreased ejection fraction, which occurs in up to 8% of patients, who often recovered. Echo and cardiac evaluation is required prior to initiating. Okay, Sydney, we're almost through. We have 2 more receptor tyrosine kinase inhibitors that we wanted to cover, which are pretty special applications.
Totally agree. We talk about them every podcast, and I can't say I've used one yet, but here we go. Larotrectinib and entrectinib are both employed for tumors with an NTRK fusion mutation. Those are extremely rare, recurring in only about 1% of all cancers. Larotrectinib is a tropomyosin receptor kinase inhibitor, and an inhibition of this tyrosine kinase blocks downstream signaling of pathways of RAS-MAPK and PI3K-AKT. This drug has an agnostic FDA approval for tumors with an NTRK gene fusion on molecular testing and was investigated in the Navigate trial. It's dosed orally BID, starting with 100 milligrams per dose. Toxicities unique to this drug include CNS effects, including cognitive impairment, dizziness, and mood disorders, skeletal fractures, and hepatotoxicities. If patients have moderate or severe hepatic impairment, it's recommended to reduce the starting dose by 50%. Similarly, entrectinib is a tyrosine kinase inhibitor, which also inhibits NTRK, ROS1, and ALK fusions. It has disease-agnostic FDA approval for patients with NTRK fusion mutations. In lung cancer, it's also approved for ROS1 mutations. This drug was evaluated in the START-RK2 trial. It's also dosed orally at 600 milligrams daily. Toxicities which are severe and unique in this drug include a risk of congestive heart failure. Like in other drugs with this risk, it's important to assess heart function before and during treatment. Additional cardiac risk includes QT prolongation. It can cause hyperuricemia, so uric acid levels need to be monitored. Additionally, it can have the same CNS effects, skeletal fractures, and hepatotoxicity as larotrectinib and can cause vision disorders like some of the ADCs. It's a substrate for CYP3A, so watch for drug interactions. These drugs sound pretty similar to me. If I do have a patient with an NTRK fusion, is there a way to pick?
Yes, there are some things that could be helpful. Entrectinib has better CNS penetration than larotrectinib, so it might be better for patients with CNS metastases. Entrectinib, because it has more targets, also has a more complex side effect profile.
Thanks. I can't wait to use them one day. That is all we have for you today. As we mentioned, this episode is not an exhaustive list. Send us a note about which agents you want to hear more about. We do hope you learned something today, and here are your key takeaways from today's episode.
Biologic and targeted therapies used in gynecologic cancers include anti-angiogenic therapies, antibody-drug conjugates, or monoclonal antibodies against cell surface receptors, and intracellular protein kinase inhibitors. It's important to know the specific mechanism of action of each individual therapy.
Administration techniques and dosing differs for each of these therapies. In general, if an antibody is part of the therapy, it will be given intravenously. Many small molecule kinase inhibitors can be administered orally. You should refer to the package insert of each therapy to review their specific administration considerations prior to giving a drug.
While many of the most common side effects are similar amongst these agents, like fatigue, nausea, vomiting, and abdominal pain, it's important to remember the unique or more serious side effects of each one. Before you start a medication, make sure that you obtain the appropriate baseline testing, like an echo for left ventricular ejection fraction, EKG if you're worried about QT prolongation and electrolyte measurements, or an ophthalmic exam, which can inform the presence of adverse events throughout treatment.
Each of these medications has specific recommendations for dose reduction versus drug discontinuation based upon the severity of adverse effect. Again, refer to the package insert for each medication to determine best management strategies should these occur.
This has been another episode of Ready Set GYO, your source for all things gynonc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready Set GYO, check out our Instagram and Twitter at Ready Set GYO.
To support us and our production of future episodes, check out our Patreon at Ready Set GYO.
This episode was recorded by Sydney Ersch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Jen McDonald, faculty at the Medical University of South Carolina, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.